So I want to thank you. Without further ado, I want to kick the mic over to Rain to get us started and hear about this wonderful project. And I also want to say thank you, Rain and Kate and Dr. Curl for being with us. This is our very first time having DOC at our community of practice. So we are so happy to have you here. Thank you.
Thank you so much for having us, and thank you all for coming. This seems like an amazing community. I'm really excited to be able to share some work with you today, but I hope to be able to just continue attending and just learning from all of you. So thank you for being here. I cannot actually see much on the screen except for the presentation, so I will try to scan the chat. I would love to be able to see your faces, but I don't think I'm able to see everything at once. So just ping me though, if there's something. We're going to try to do questions at the end, but I do want to try to interact as much as I can and just ask if you're familiar with things. So if you feel inclined to respond, please do. Okay, so we are excited to share with you our project today on implementing evidence-based quality indicators to improve treatment outcomes and job satisfaction. And we've already been introduced, so I'm not going to do that. We will kind of take turns sharing and presenting today, so you'll hear from all three of us. Okay, so there's our disclosure. We can keep moving through that. Okay, you can see some educational objectives on the screen. We want to talk to you about the link between quality indicators, our services, client recovery, staff burnout. That's like a big mouthful. We are going to try to break that down. We're going to show you some steps in creating correctional healthcare and looking at some positive outcomes. So to start, we just want to talk to you a little bit about kind of the who, what, why, the how, like of this presentation and of this project. And so who we're talking about is women coming to and going through prison. And this is really important because these women are our sisters, our mothers, our daughters, neighbors, friends, any kind of family you can imagine. Only 1% of our population stays in prison. So most of these folks are someone that we know or will engage with. And the what we're measuring is looking at treatment outcomes or quality indicators. There's only so many hours in a day, so many dollars available, and there's a really critical opportunity in prison, as strange as it may seem if this is not kind of your world, to disrupt the incarceration cycle through giving quality treatment. Why we are doing this is to change women's pathway and improve quality of life for all Washingtonians, not just the women that we're serving here. And that's through treating trauma and SUD that we know are recidivistic factors for the women that are incarcerated here. And we're going to talk about how we've done that, as well as look at some of our results of our metrics and then kind of next steps. So to start with, I just want to share a little bit of a story because I find stories really powerful. And I think it's really easy to get lost in data and metrics. But it's really important based on kind of that who. So this is that who part to remember who we're really talking about, which is the women that we serve here. And a lot of us working here just want to acknowledge that we have a lot of privilege. We're free, we're educated, white skin. A lot of us, not all of us, speak for myself. And so it's really important for me to elevate the voices of the people that we're serving that are often facing a lot of barriers that I'm not facing, right? So the story that I want to share for you is the first person that I was ever able to provide an evidence-based care intervention to in 2014. And I want to show that to sort of talk about women's pathway to crime. Okay, so on the next slide, okay, so I can't see you guys, but how many of you are actually familiar with kind of like women's pathway to prison? Like maybe, is anyone familiar with that? Possibly put it in the chat. Maybe if you are, I'll kind of keep an eye out. If you're not, women's pathway, the research-based pathway to prison is trauma. So people have childhood sexual abuse, childhood neglect, all of those sort of things. And that really diverts developmental processes into survival processes. And so girls, because we're really talking about girls at this point, are missing critical opportunities to learn things like how to manage emotions, set boundaries, navigate relationships. And then in order to cope with that, women typically turn to substance use at some point, sometimes at a very early age. And when substances are introduced, this really amplifies dangerous situations and further compromises decision-making abilities. And so the woman that I'm thinking about, she really lived this pathway. In this client's life, she really went through quite a bit of sexual and physical violence in her childhood, as well as adult sexual assault. She also had methamphetamine addiction. And this really led to compromised relationships, and it led to criminal activity so she could both sustain connection and maintain addiction, and that led her to us. So before we made the switch from measuring process to measuring quality of treatment, we would have measured the process of this woman going through prison. Like we would have said, like, did she get an intake? Yes, she did. Did she get a diagnosis of PTSD? Yes. You know, did she get a treatment plan? Yes. But that really would have been the end of it. We would have kind of just checked the boxes of like, we did do the correct process. And she would have likely released and potentially come back, and we would have just done it all over again because we hadn't treated those big steps that you're seeing on the screen of trauma and substance use. And so that is like not what we want to be doing, right? And so before we made that switch from process to measuring and quality of treatment, that would have been the end. So when we moved to measuring quality of treatment by using quality indicators, we started measuring recovery. And that's really the power of measurement, is that you measure what you value. And we as an agency and as a mental health team, we really value healing and recovery because that's better for the women we serve and that's better for the community. And so we started asking really important quality questions like, is treatment working? For her, yes, it was. Like, did we treat her trauma effectively? Yes, we did. And that really enabled her to break the cycle and not come back. And she was never part of our metrics again. And that is like literally the goal, right? Is for people to break and get out. So that case, that decision, that sort of fork in the road back in 2014 is really what helped us take another direction, and kind of, you're going to see sort of the waterfall of that today. So even though we're going to talk a lot about data and process today, we're really simultaneously talking about women's lives and women that we care about in our community. And so I just really want to ground us in that before we move forward. And just scanning the chance. Oh, awesome. Someone formerly incarcerated. That's amazing. Only with Indigenous rural communities, new for me. Okay, so some people with lived experience, which is amazing, and some people with like familiar through like research or academic, that's great. Okay, so now that you're kind of familiar, of like a really brief level, obviously, but of women's pathway through to prison, I want to talk about women's pathway through prison because there's actually a parallel. So this, what you're seeing on the screen should look really familiar to you, to that like first slide, right? And so women's pathway through prison looks very similar. So they come into us at intake, and 80% of the women that we see are telling us that they've had severe lifetime trauma, which makes sense based on their pathway to prison. And then out of the mental health clients that we see, about 61% of those clients have a PTSD diagnosis, and about 62% of those clients have an SED diagnosis, which is huge, right? It really validates that pathway to prison, sort of starting through prison. Once women are incarcerated, they don't have as much access to substances, which means they have to look for other ways to cope with these untreated trauma symptoms. And sometimes that leads to things like aggression or anger because they might be reacting from a fight or flight place, self-harm, crisis. So other coping things kind of come up, and those things do actually get them in just as much trouble. So even though they are in prison already, that can lead to sanctions in terms of infractions or restrictive housing. So this is like a really critical pathway that just repeats once women get it. This is obviously a huge burden on the women that we serve, but it's also a huge burden on the staff that are here providing the care. And so what you're seeing on the screen now is on the left, at least it's my left, so hopefully it's your left, is like the mental health code or the S code. That's like an indicator of sort of clients that we're seeing that have needs and sort of their functionality. And the women that are living in our general population that have a lot of these needs are in that yellow and light green bar. And so what that's showing you is that we have a huge amount of women that are in crisis due to these untreated symptoms that are needing immediate intervention. And on the right, you can see how many clients we're seeing immediately, which is about 60%. That burden means that we're constantly just sort of responding in crisis and not really having a very thoughtful sort of proactive intervention, which is not great for women, obviously, but it also really burns the staff out. And it really prevents staff from doing the work that they really want to do, which is meaningful intervention. So it has this burden of untreated trauma and substance use is high for both women and for staff. Okay, so now that we have, how are you guys doing out there? Are you doing okay? I will look in the chat. If you're like, no, I'm not okay, I need to know that. I want to know that you're okay out there.
We're good. We're good.
Okay. So now that you know a little bit about kind of this pathway, it's probably really obvious why we need to intervene, but I'm a psychologist, so of course I need to tell you a lot about why. But also it is important to share why. So one of the reasons is that treatment works, right? And so a lot of our women, including a lot of our staff, don't know that PTSD is actually a treatable condition. And so this is just one of the treatments that we offer, cognitive processing therapy. But you can see that after 12 weeks of treatment, about 53 people that go through this treatment no longer have a diagnosis of PTSD, which is huge and usually shocking to people. And so one of the things that we want to do is we want to provide effective treatment that can heal. Another reason is that prison is a critical intervention point. Yeah, no, it's good. Keep going, Kate. Yeah, prison is a critical intervention point to provide this care. And so one of the things implementation science tells us is that it takes about 17 years for evidence-based care to reach routine care, which is mind-blowing. And that doesn't even include prison. So it's likely our clients with all these barriers that are facing in the community, being unhoused, oppression from racism or homophobia, all these other things, limited access to care, the impact of COVID, all these really intense barriers that they're facing. It's very unlikely they've had access to this before. In addition, prison provides time and space for that treatment if you truly can make it a therapeutic place. That prison can be safe for intervention, and the research shows that. And then, like I said, most of our clients have not even had access to this. Healing is foreign. So like if we can use this space for quality care, this is a really powerful place to stand. Additionally, untreated trauma and substance use, we know that the research shows us that this leads to recidivism, which probably makes sense, right? Like if you're thinking about those pathways to crime. And so this study by Seda McNeil, basically what you're seeing on the screen is that people that have SUD, PTSD, or combined, which is sort of that third bar there, can help predict arrest 12 months after release, or even new felony charge 12 months after release. So we know that intervening here is a critical way to interrupt this, which is critical for all of us living in the community and sort of riding the wave of what happens when this happens to our community. Other reasons that are important are global public health policy. So anyone familiar with Mandela rules? You do, maybe say something in the chat. The Mandela rules are critical. They're from the United Nations, and they basically say that people living in prison, yes, someone is good, should have equitable health care to the community, right? And not only that, but prisons are responsible for evaluating, promoting, protecting, and improving the life of incarcerated people. So measuring quality health care directly links to that mandate. Lastly, we also care immensely about the staff that are here. Obviously, the women are a priority, but our staff are also our priority. And what we found is that when you support staff to do this really meaningful work, this evidence-based care to treat trauma, you might think that they would be particularly exhausted or taxed by this, but actually what the research is finding and what we're finding is that that meaningful work actually increases empathy, attunement, and nourishes and sustains clinicians, which is really amazing. Right. So if you leave space for people to connect as people and really raise up that humanity of healing, that means something on both sides and actually protects both sides. Okay, so we've talked about the who, we've talked about kind of like that, you know, how we've gotten the why, right? And so it's kind of time to look at the how. So on your screen, you're gonna see like a timeline slide, but hopefully, okay, good, it was like, here it goes. This was actually the brainchild of Kate, who's going to talk in a few minutes. And I love this slide. And one of the reasons I love it is because it shows that this process didn't happen overnight. And it actually took quite a while. And I think what's really powerful about that is that small steps do make change. And so I don't know where all of you are in sort of your professional journey. So maybe some of you have already done this and they're like, yes, absolutely, I've already done this. Or maybe you're just starting. But really taking a small step is really critical. And so you can kind of see some of the highlights on the slide that we're going to go over in a minute, kind of one by one. You can see it started in 2015 and it's still ongoing, right? So we're about to hit sort of that 10-year mark. So how many of you have faced the challenge of having a fully functioning team? I certainly have. I think most people have. This is a really huge barrier for a lot of people for a lot of reasons in state service. So that is sort of that 2015 where we really switched our focus to like, how can we make a healthy, functioning, strong team? Some of the barriers that we had to address to make that happen was, you know, there's lack of training and resources like accountability and competence. We didn't have any research software, you know, healthcare record, limited staffing and burnout. These were some of the things that were really on our radar of like, how are we going to like cope with this? So our turning point really was that we realized that we could either kind of keep focusing on these challenges because we were living, like I showed you kind of at the beginning, that reactive crisis-driven state, immediate care needs, untreated things driving all this burnout. Or we could stop surviving and start living, right? We could accept that we were not going to get any more money, not going to get any more resources or more staffing, and like actually think about like what could we do with what we have. So that fork in the road after we ran that one case and we started building this team really was a point of radical acceptance. It really was like, okay, we're standing here. We can either continue to run like this or we can just shift inside, right? You can be the change that you want to have happen. And I think that in that reflection series, we talked about that a little bit. So we decided to build something. We were going to start at the ground level with really small steps, which led to partnerships with some of the people you see on the screen today, who are just fabulous people, which led to creating these metrics, which led to results. There were definitely barriers. And so data barriers are huge. I'm curious if any of you are facing those. I don't know, but inside of DOC, data barriers are pretty big. And you can see on the right, kind of like the research around why these data barriers are hard. So like the research really shows that prison has barriers related to resource constraints and kind of data functionality. And so that's usually a lot of the reason why indicators tend to be process-based instead of quality-based, right? And so, sorry, just checking the chat. So we took some really small steps. So team members that were interested in entering paper and pencil data into Excel, which I know sounds insane, but that is the world that we live in, took that on and they were like, wow, we got to raise this data up somehow, right? And that operational data really clarified women's needs. And we took that data to headquarters. We were like, hey, this is what our women are saying. This is their voice. This is their forms that they're filling out. They're really telling us that they need treatment for these things. We need help with this. And that led to headquarters being like, okay, this is important. We should build this relationship. And we started to get a relationship with our research data team. And so to kind of talk about how we did that, because this is about the how, I'm going to turn this over to my partner, Kate, to talk about how we did the facing these barriers and overcoming.
Thank you, Dr. Carei. And now we're going to talk a lot about barriers and how we solve them and are still solving them. Because correctional healthcare systems are really suffering from a lack of standardized reporting. And this is logistical constraints, funding constraints, limited staffing to support the system management and training. And this really aligns with our barrier as well. There is no electronic healthcare record, which limits our ability to measure achievable, relevant, and time-based targets really significantly. We do at DOC have an electronic patient management system, but it really isn't set up with the functionality that's giving us the ability to capture the details necessary to install evidence-based practices. And it's really just a modest patient scheduling tool, and clinical data variables that you see within healthcare systems usually come in a blueprint of a targeted EHR, and Omni has none of those features. So anytime that we're installing a quality indicator or any type of metrics, we actually have to take a clinical and administrative problem solving session, really, because visibility constraints on the administrative infrastructure, which include like barriers to uh, appointment slots and oversight of why appointments are being missed in our system, make really system level super difficult, right? And clinically, as she's been talking about earlier, evidence-based practices play a vital role in maximizing the client healing. So we really have to solve these problems. From a data perspective, how we do that is to extract relevant information. We actually have to bridge the gap in our system limitations with a shared language. We literally have to develop code criteria and put it into the system. And before we move on, we really have to keep in mind that because this is a free-form system, having multidisciplinary evaluations of the sensitivity of these clinical and administrative components is always needed if you want to maintain this clear language in the lack of an EHR. So after after the data is collected and the shared language is developed, we had another barrier. And that was actually we had to install clinical scheduling expectations, administrative monitoring processes, i.e., running reports, and really put in place best practices to support the infrastructure for visibility and access. And to do this, Dr. Carei started by making a waterfall schedule. The post-its that you actually see on the screen is basically a visual representation of individual appointment slots, group therapy slots, all of these things. And they allow space for benchmarks of quality indicators to be met within the system. And this is a really cool thing because it later was all digitized and put to our patient scheduling system. And another shared language to keep these referrals coming in was developed so that we could communicate accurately within the system for time-based goals. And quality improvement, we need to talk about that here, right? If it is successful, we have to have visibility, but we also have to have areas where we're fostering open and honest communication. And these need to happen in a non-biased way. See, within correctional healthcare, some of the things that we face is our medical staff have limits on getting access to their patients. There are security challenges and a lot of logistical barriers, right? And another challenge is that communication to our appointment or to our patients for the service times can be delayed. And this leads to even further silos, which is causing more stress on staff and more stress on patients that are trying to do these great work, right? So establishing cross-divisional partnerships that allow for these communication points is super important. And that's what we actually saw here. See, getting visibility by way of aggregated data allowed us to have a crucial conversation with our custody partners, which allowed more movements into our clinic, and then eventually allowed our staff to have a 410 schedule because burnout is pretty high in our setting. So the next thing we really want to talk about is sharing data. And on the screen, you can see a whole bunch of ways that this team's doing that. And data visibility is super important. Like, we don't have a lot of research into targeted areas in correctional healthcare, and that's why it's both fascinating and we're always problem solving. But it leads to a lot of unique health stress challenges for staff and patients. And so being able to visualize this data is really exciting to people. And so we are sharing constantly, but we also want to talk about the quality improvement program from the disclaimer that you saw earlier. See, our program looks at areas of improvement and really seeks to respond to best practices. And this isn't just the leads at headquarters. These are actual people closest to the work doing the work. And at WCCW, they actually continued their spread on their waterfall schedule, and they allowed for eventually installing quality indicators around cancer, diabetes, and hypertension to be far more easily installed at this location than others because we had our access to care already set up, right? That scheduling referral practice is super easy once you have your base. And nationally, data around women and mental health services is almost invisible, as you can see. And that's why research is so vital. And you'll go into trends and tracks and things like that later with Dr. Carei. But locally, we need to make sure that improvement projects like these, done by the people closest to the work, have awesome visibility because it gives happiness back to staff. It starts giving patients more healing. And as you'll see later, it leads to some really positive trends as far as healing goes. But we still have one other barrier that we're problem solving, and that is really hand collection of data without an EHR. And DOC is super driven by lean practices. We are in a constant lean practice and quality improvement. But one of the most special changes, and you'll hear from her later, is Dr. MaryAnn Curl. And she joined us in 2022. One of her very first changes was to make a clinical service board. She had heard that we were having trouble and she wanted to have an area where clinical leads that wanted to support system level changes to go. So the clinical service board is really special. It has all the FMDs, facility medical directors, and site volunteers from every modality, and they work hand in hand to develop system level changes that we want to see. And DOC doesn't really want to be a top-down leadership. Policies and protocols are super important, but so is being conducive and responsive to our staff. And that actually leads to the best outcomes. And that's actually scientific inside of a supply chain, right? We need to give those closest to the work the autonomy to do it. And so we just want to thank Dr. Curl openly here for her wonderful contribution. And we're going to pass it back to Dr. Carei so that we can see some of these trends.
Thanks, Kate. That was awesome. I am so grateful for people that can help me navigate these barriers because these are immense. Okay, so recap before we sort of move out of kind of like the how and into some of these results is just that we have these process indicators that were really kind of like met or not met, right? And so they answered like our policy driven questions, which is a great place to sort of set the stage of like where these things completed. And one of the things that we did around that, even before we were started making this change, is we started like a pre-fiscal quarter meeting with our staff, and then a post-fiscal quarter meeting to say like, hey, these are your targets for the coming quarter. Like, how well do you feel like you can meet these? What kind of support do you need to meet these sort of metrics, even when we were sort of in that process place? And after the presentation, or if you choose to look at it online, there's kind of an appendix that sort of breaks that down for you if you want to see that. But this culture change that Kate is really talking about, and Dr. Curl will talk about later, of sort of like shifting from process to quality, and also really I credit Dr. Curl here with this of the like yes culture, which is just huge, like has really shifted our ability to like measure and engage from sort of like, did we do the checklist to can we measure that value that we have, right? That heart of like helping people recover. And so that's moved us to these quality indicators that we're going to now look at here in a minute, to sort of look at the answers of like, was care effective, right? Like, did it help reduce some of these outcomes in the facility that we worry about that can unintentionally further complicate things for the women we serve and the community that we serve. So I'm going to show you two of those today. So on your screen, you're going to see the trauma in a minute, the trauma treatment client improvement one, and the facility safety. We do have a lot of other quality indicators, but I didn't want to just like drown people with them today. So if you are interested though, and this is something you're passionate about, please reach out to me. WCCW is the only prison nationally recognized by the Council of State Governments. Okay, you want to go back a little bit. By the Council of State Governments as a peer-to-peer training agency. So literally our job and our passion to help. So if you want to reach out, please do. So the slide you see now that says behind the scenes, I think this is a really critical slide because it does show that behind these quality indicators that we're going to kind of breeze through in a minute is a lot of work, right? It's not like you just sort of like one day are like, oh, I want to have this quality indicator. And I think it goes back to sort of that timeline slide. And so you can see sort of like just a summary where we talked about sort of this ideas, the why, like it was driving sort of our sort of first step on this path towards quality indicators, and how Kate kind of and I both talked about facility connections, administrative stuff, which we're sort of leading up to with Dr. Curl. I talked a little bit about those research partnerships. This then became deeply clinical. So like for those of you that are in healthcare, yes, I will share my information for sure. I saw that chat. It became really deeply clinical where we could like mentor our staff and help them through this process. And then that leads obviously directly to our patients, who also are really the first stepping stone of telling us what they need, right? And that led to these quality metrics. So why don't we take a look at two of them? So the first one is the trauma treatment client improvement. So hopefully by now I have sold you on the criticalness, because I feel obviously deeply passionate about this, about treating trauma. And so one of the things that we do when women are in trauma treatment is they fill out this questionnaire that you can see, which is about trauma symptoms. And the purpose is we want to make sure that treatment is working. The women just aren't like coming to our offices and seeing us and nothing is getting better, right? Like we have to show up for them. We have to help them in this critical intervention point. So we have them fill this out, and then you can see that that is at the bottom. It tells you we want to, what? Did I miss something? Okay. We want to be able to look for a 10 to 20 point change, which is nationally considered clinically significant. So that is sort of part of what we're looking for. So this next slide shows you the results of that. And so it shows you that for these different treatments, which is really what you're seeing on the screen, there are actually 6 of them. This is just 3. The one that's the green and orange is written exposure therapy. The one in the middle is a group exposure therapy called SHARE. And the one on the right is cognitive processing therapy, which had that handout way back at the beginning. So what you can see is that 76% of our women that are completing trauma treatment no longer have any clinically significant trauma symptoms, which is amazing, right? It also helps me as a supervisor when I'm working with folks to be like, okay, which treatments seem to be working better and why? And you can see some behind the scenes sort of like slides at the end. And also we can't share this obviously on here, but we can look at client details about like how every individual client is doing and what might we need to do to make that better. So this is really critical. And this metric helps us know if we're on track, if we're helping women, if we're changing that recidivism path. Another metric that we have is facility. Oh, wait, I got to say this. So that also shows that their dropout rates are lower. So that metric is also really cool. I almost skipped over that. So in the community, dropout rates for trauma treatment are about 30%. And in here, they are actually under 20. So this is awesome because I think clients and staff are sometimes nervous to engage in treatment. But the research that we have here really shows that it's worth it and that clients stay in it. Okay, so now to facility safety, the other metric I want to share with you. So this is really targeting how trauma shows up in that pathway through prison that I talked about at the beginning. And so we know that people with PTSD are more likely to use substances to cope, right? And that can lead to infractions. And we also know that people with PTSD sometimes are responding to things through fight or flight, which means that a situation we may not think is particularly threatening may feel very threatening to the client. And so that could go really badly, right? They can get infracted, they could go to restricted housing, and this is like a really critical thing that we need to intervene on. And there is a link there later. If you download the slides, you can see a little more about the details behind this metric, but we're going to show you kind of the results of the metric. And so what you can see on the screen is actually not only our metric, but we actually have work that's in review for publication right now. And so the preliminary results show that people that have gone through trauma treatment, right, our clients, that there is a huge reduction in infractions for the women that are going through this trauma treatment. About almost 70% of women are decreasing their in-prison infraction behavior, which is meaningful for 2 reasons, right? It's meaningful for the facility because we care about the women and the staff that are living here, but we also care about how this translates to the community, right? And so like if we can get women to heal here and have less problematic behaviors here, what we really hope is when they come home to you that this sticks, right? And you can see that sort of that orange bar that women that are not receiving this treatment with trauma actually have an increase in infractions. And I think that's really important because trauma doesn't just go away. It's not something that you can just like let go and it gets better, right? It stays very, very high. Okay, so the other thing I want to highlight is sort of eliminating waste with these evidence-based practices and these quality indicators. So time is precious. When we have people's families members here, we take that very seriously. And so the metrics can pinpoint any delay in our workflow. And in terms of resources, we're moving from paper to electronic, which is critical. We're also optimizing our process and systems, right? And you can see that sort of listed there. In terms of monitor and respond, our indicators, like I already said, help me know what I need to do more of or less of, intervene individually with clients and with staff that I supervise, as well as improving patient safety, literally by decreasing infractions in the facility, which someday I hope to look at, does that continue into the community? I very much hope so. And preventing readmissions by treating these recidivistic factors. And it also helps with our retainment of our staff, especially on our mental health team, but other places as well, because we can reduce this crisis-driven work that doesn't feel thoughtful and meaningful, and we can engage with more humanity, staff and clients are happier, right? So that leads us to those improving client outcomes. And you can see that like from that one case, sort of at the beginning of the story, we have that one case, and now we have several hundred cases that are completed that we can review. So it's been very meaningful and powerful. So I'm gonna hand it over now to Dr. Curl, my partner, to talk about kind of this, bringing it back to this joint story.
Thank you, Dr. Carei. So what you've been told so far is that we noticed that when we shifted from a kind of focus on just getting the steps made, that those process kind of indicators were only kind of the bricks in the road. And when we raised our eyes up and we looked around to the right and to the left, the staff that were with us and the patients that were walking the road with us, we realized that actually looking at the culture around how we were kind of conceiving of our environment, going from a kind of a deficit environment to a strength-based approach, and asking ourselves, what can we do with what we have? And then asking ourselves, is this making a difference? Starting with the patients themselves, is this making a difference for their ability to have a life that is worth living? We realized then the byproduct of that was that we also started feeling like we had a life that was worth living as a result of engaging with empathy and acting with the compassion that flowed from that empathy. And the really cool thing, and one thing I love about this visual, is once you start kind of stacking up the positive factors, and you start kind of the momentum and the kinetic energy of barriers starting to come down, there became this really excited synergy that we saw in our culture, and that we saw really have a huge effect on beginning the next improvement and the next improvement. And it really is so gratifying to be able to be a part of something like this. Yeah, please go ahead and go on to the next one. It as a leader, what you hope is that you will um, uh, find people who you can lift up. One of the things that Rain said, and my version of what she said was, as we elevate ourselves, we lift others. And that is, to me, the very definition of what state leadership should look like, is we're looking at Washington becoming as healthy as we possibly can, with corrections being a huge part of our public health system. And as we prove that prison can actually be the safest healing space for people, and that we can take there's about an average of about 30 months that we have the pleasure of interacting with our patients, and then they generally will move back into the community to kind of test out the lessons that we've been working on and walking the road with them on. And as we see them be able to leave and be successful, we believe that we're proving that prison can actually be a space of recovery. The really cool part of getting to be me in this is I get to help decide some of the ways that we leverage the connection that we're trying to make. We've been able to go through several books. If you want to go ahead and go to the next one, I can say these talking points with that one in front. This is a really cool book, and it's sorry, it's a little bit blurry. The original thought that the author had when he wrote this book, he's a doctoral PT provider, and it was deep in the middle of COVID, and he was kind of having to put his clinical work a little bit on some kind of slow go. And so he actually took a deep dive into the meaning of the work that we do. And there are in this book 11 kind of aspects or facets of care. And I will say it's not a pricey book. And it's one that I would say get, and who cares if you're in healthcare? It's about humanizing the interactions with other humans. And you can take this and you can generalize this to accounting. You can generalize this to systems work. You can, if you're a consultant that you're working with someone, it's a really great kind of lens to put on how you do what you do. We, of course, had it as a readily applicable application for the process that we go through and the support that we give for healing people and helping people to heal, because we really do believe that it is through the pain and the trauma that people have, that they've been wounded, and that recovery is absolutely possible, and that treating people actually does change their lives. And again, the happy thing is that it also changes ours. We've been able to go through 3 other books. The 5 Dysfunctions of the Team is one that probably most of you have gone through. There's also a really great book called The Coaching Habit, on how to, as a leader, to keep yourself from tripping over your own ego, and helping to bring out the best in the people that you're leading with, rather than acting like you're the fount of all knowledge, which is especially for leaders who are early in their career. We feel like we need to, be brave and be out there in front. And I think as I've mellowed as a leader, I've realized, no, this is actually about quite the opposite of really trying to set people up for success. And then the other book that's mentioned at the bottom is the Florence Prescription. And that's a really fun fictional account of Florence Nightingale coming into a modern hospital system and saying, gosh, these people don't, own what they own. And it was us setting ourselves up to be an ownership culture. And so we've been able to do that. We have actually a culture huddle every Thursday for 30 minutes, where we're able to kind of talk through, just as a team who care about each other. Right now, we're actually doing holiday playlist and some fun, frivolous things. And so we've kind of been having fun with that. And then we'll get back to some of the coaching habit and some of the lean transformation items in the culture huddle on the Thursdays on in January. So this is kind of the visual is our patients are really the center of what we do. And when Rain is talking about doing kind of getting the feedback on whether or not what we're doing works, there's this for whom piece of it that was absolutely essential to why we wanted to be visible with the outcomes that we had. Is this working for the patients? Is this actually creating a space where they can leverage the strengths that we have in our team and heal and learn what they need to learn? And so everything we do centers around the patients and their experience of what they're going through, and their acquiring better health literacy and a better ability to effectively put the practices into place for their lives. And when they leave us, the proof is along the way of is it getting easier? Is it getting something that they can handle more readily in their lives? And then the proof for us is have they sufficiently learned what they needed to while they were in our healing space to then go and have a successful life that they're able to feel proud of when they leave, and unencumbered by the trauma of the past. It, as Rain would tell you, it's not ever 100%. People do have times where things are heavy for them, but have we given them the tools in their toolbox so they can manage? Go ahead to the next one. So these are the dividends, better outcomes for our patients, healthier Washington. That's what we are pretty obsessed with, is being a part of. We're very proud to be a part of the healthcare system in Washington, and we are intent on our lives being invested in creating healthier communities. Utilization of services. Are people getting the access that they need, and are they are we distributing the resources in an equitable and appropriate way, so that all boats can be raised. Informed decision making. This is an absolutely huge thing, and this has the double entendre of not only are we trying to leverage the data that we have, but how we're sharing the data with each other. And so that's staff using it as a collaborative rather than a competitive. It's following a process of humble inquiry where we say, wow, that didn't exactly work out exactly the way that I thought it would. Let's go for another plan, do, check, act cycle, and checking back in with that. By the way, I would say that there are two things missing on the plan, do, check, act. And the first one is belief that what you're doing is to make a difference. And then you do your plan, do, check, act, and then you do your share. So we need to have PDCA be bigger, because the share is the part that is transforming our work. We're having collaboratives every 2 weeks where we really share not only the barriers and the challenges that we had, but the victories and the breakthroughs. Because what we're doing is we're learning about our systems, and we're learning about the people that we work with. And that belief that we can make a difference is huge for us. So improving the patient-centered care is an ongoing thing. This is our 3rd year. We're coming up in April on beginning our 4th year of patient-centered medical home. And we have actually presented, Talia, I think you said we hadn't presented yet, but this is our 4th time to present. And our thought is we're going to try to maybe present at least once a year where we give you guys a bit of an update. It's probably time to give one, but this is a really great place to give you a snapshot of excellence in our system. Go ahead. So next steps, Rain, do you wanna go ahead and take this one and wrap it up?
I was really into what you were saying. I was like, oh, we need to adjust that with that brief. So cool. Okay, next steps of our journey, sort of wrapping up before we go to like our question and answer, is just continuing to build these quality indicators to support incarcerated women and Washingtonians. Building a healthy work environment. We want to keep decreasing waste, making things more efficient, using the tax dollars that you all contribute to this important work very, very carefully and judiciously. We want to keep building relationships and expand capacity in a lot of different ways. I think Dr. Curl is an amazing leader for that. She's already asked, like, where can we take this next? Continue that equitable work, both like in terms of like helping all of the women that we serve with these immense marginalized experiences and oppressive experiences, and also equitable financially, making sure that we're being really responsible financially. And we want to collaborate with others who share the vision of healing, recovery, and lean and patient-centered work, which is all of you. So thank you so much for having us today. And that leads us just to our last slide, which is questions and comments. Also gives you a link to our CSG recognition site. So please reach out, and I will put my information in the chat in a few minutes. So what questions can we answer for you as a team, or what would you like to share with us that we should?
Yes, you have some great questions. And I just want to say, first of all, thank you to you 3. This is an amazing presentation. I can't tell you how many times I hearted it throughout. I'm like, can I just keep the heart like nonstop? This is such good presentation. You have so many comments throughout the chat of folks really seeing the impact and just how powerful this work is. So thank you. And yes, you're right, Dr. Curl, you all have presented numerous times, but not at our COP. So that's what I was referring to. We're just so excited to have you. For those that know me, you know I have an affinity for this population and this work. And with that, I also want to send a shout out to some folks in the audience from OCO. And if you don't know what that is, that's the Office of Corrections Ombuds. They're also advocates of people who are incarcerated. And so they do great, important work too. So they're here to also support this great message from DOC. And so, yeah, with that, we have some awesome questions. One of them is, are you already seeing recidivism rate changes as a result of this work, or do you plan on measuring it downstream?
Oh, that's such a good question. So I could fully nerd out on this question, so I will hold myself back a little bit, but one, there's 2 papers that are under review for publication, so I will for sure share those when they are out. But what we did see some decreases in the means for recidivism with this work, but it wasn't at a significant level. And I think that's probably related to the N, kind of the size of the sample that we had, because we were looking back, right? So I think like looking forward, I'd be really interested in that. The other thing that I think that I've really learned through this research is just how complicated recidivism was. I think I have really started to appreciate like how much it takes to move that needle. And I think that one of the things I'm learning in the research is how much that continuity of care makes an impact on recidivism. And I'm wondering, I guess, if there's a way in the future to show that this lessens the burden on the community in terms of these women that we're serving will need less intensive services upon release, right? Because they no longer need evidence-based, high-level acute trauma care. Does that move recidivism alone? I mean, I don't know. I'm guessing that a lot of things move recidivism in terms of social support, having a house, being able to have a job, your education, all those things coming together. But the short answer is yes, that's on my list, and please hold me accountable for that.
Hey, Ryan.
Yeah.
Just because it's pretty darned impressive. I will say, so this isn't just for the women's side, but the whole system, all of DOC. In the last 4 years, we've gone from a 33% recidivism rate to a 22% recidivism rate. So taking this humanitarian approach and this actually treatment-based approach has been a huge amid the other approaches that we've had, but this is major.
Awesome, thank you. All right, well, another question regarding your figure 5, how much time has passed in your comparison of infractions between the 2 groups?
That is a great question. So we limited it that when we looked at that. So again, it was a looking back sample to looking at women that had at least 18 months before, at least 24 months during their treatment, and at least 36 months after treatment. So it was a decent amount of time to be looking at that drop.
Good deal. Oh, here's a good one too. Are you considering applying this work to the male population as well?
Yes. We do, and we consider how to do it even more avidly. Dr. Carei and her colleagues have blazed a trail, and certainly this is applicable, and we would like to take the lessons and carry them across, but we already do to a certain extent. We'd just like it to even be a stronger link.
One of the cool things that Dr. Curl doesn't even know she did is that we were actually restricted from like a lot of the system use that actually prevented the spread. And so anytime we do anything, it's a test and then a spread only if it's successful. And so the success point was only able to stop at WCCW because we had leadership and foundational things, but we're actually getting taxonomy and we're getting drop downs. And once we have drop downs, then we can spread. Pretty neat. And so thank you, Dr. Curl, just to shout out to how cool you are.
Okay, so that goes to having the clinical services board and having leaders who are statewide leaders that help to kind of translate things from one success over and propagate other successes. And that's not just me. That's a lot of people listening in one venue and then sharing over great ideas in another, and connecting people. But it does help to have things like we started an administrative services board for our administrative colleagues. We have a quality council. So structure does help, because then it helps with just the communication piece and the ongoing support that people need.
Awesome, thank you. You know, and as you talk about all the folks that are involved, that reminds me. So I know the audience, you all have heard about this before, but I've talked about doing a reflection series, and that's where Results Washington, where we like conduct interviews with subject matter experts of great projects like this all throughout the state. And it's similar to this, only more of an intimate dialogue of Q&A back and forth between me and whoever I'm interviewing, and there's no slides, right? And so I did this with Miss MaryAnn Curl, and we talked about this project. And I just want to say that it was very apparent, not only the passion that you're seeing from these three ladies in that interview, but also just how powerful it is to have supportive leadership and just a really engaged team who is passionate about the work. It takes a village to do work like this. And so to hear her tell this story, as you all have heard today, it really is impactful. And I also want to share one more thing. When you were talking about what is it, radical acceptance and creativity, and you were talking about, facing barriers and then just getting to the point of realizing, okay, we can't necessarily do anything about these things that are out of our control. And you said something during that interview, which I'm also going to say here, and I have it written on a post-it on my computer ever since I talked to you, Rain. And you said, move forward anyway. And that was just so powerful to me during that interview. And then it brought it back to my recollection when you talked about it today. And so I just want to throw that out there for folks to encourage you that sometimes there's going to be things that happen that are out of your control. And you're going to have to embrace the concept of radical acceptance and get creative with what you have to work with and move forward anyway. So that was definitely something that Rain shared with me that has stuck with me ever since. And if you haven't had a chance to check out that reflection series, you can find that on our agency spotlight page, also in our website, results.wa.gov. Okay, sorry, just had to throw that in there. There's a couple more questions. And so here we go with Megan. She says, I'm a data nerd and I have a few more questions, and we love you, Megan, and you're amazing. So bring on those data questions. And she says, how often are you reviewing the data you're collecting? Are you planning to conduct any deeper analysis with RDA? And are there any plans for rolling this out to men in Washington prisons, which you already answered that pretty much.
Yeah, I feel like Kate and I could team tag this, so I can start part of it, but I feel like Kate might want to say something more about kind of like rollouts and drop downs and stuff. So we review this data really regularly, so I actually can see it every week on our women to see like how their improvement is going. So that's actually in real time, and I think Kate can talk a little more about the data, and it's pretty awesome. So I'm gonna tag Kate because she's actually really good at sort of like dashboards and metrics and stuff. So do you want to say something, Kate, or do you want me to keep talking?
So how often the data is refreshed is dependent on the dashboard, right? And so our CQuip teams are meeting bi-weekly and they're reviewing data monthly. Dr. Carei and her team do a different type of review, which is the health services manager and their quality improvement nurse and her, and they do that monthly. And so it's really impactful. Like you have to allow for like positive feedback from the staff that are actually impacting the metrics, because we don't have an EHR, so we have to install all of these freeform things into it. And so having these meetings is super important because they'll literally tell you everything that's wrong with the dashboard. And the cool thing is you can keep mapping them. So like one of the things that needs to happen with like mental health is like we're going to take like SIPS data and we're going to like map it in, so we're not like dependent on someone updating a code in Omni, for example. We're looking at the distribution of the medication. The neat thing is though, like the WCCW platform for their CQuip teams, which is bi-weekly meetings, monthly data reviews, was spread, and it is spread by patient-centered medical home, and they're all combining, and we're meeting a ton. Like we are talking about data all the time. Dr. Curl probably can tell you about, we call it the war room. It sounds like terrible, but it's really just data, and you just like walk in and you just like look and see where everything is. And so like continuity of care wise, we can literally see when we make platforms of care and we have systems, we can just operate, like put in the data and make a system very easily. But you have to review it constantly, and you have to have an RDA team that's really okay with making a lot of changes, because we do not have an EHR, and so we are making changes constantly. And
Thank
Dr. Curl
you.
probably wants to like say a lot about like patient-centered medical home because it really is nothing but making data-driven decisions. Like culture, yes, heart, yes, healing, yes, but it's all based on statistics.
Fantastic. Thank you so much. Yeah, this is not easy work. I work in a state government agency that links a lot of state government data together. And like, that's a whole layer of complexity on top of what you all are doing, which is actually collecting the data yourselves
Mhm.
and then trying to process it. But yeah,
Yeah.
also understanding it from the patient and the process perspective. Not everyone does that and not everyone does it well. And so just kudos again to you all.
So one of the cool things that we did is in 20, so we used to have like singular people in charge of our system. And in 2020, we actually made a super users team that started looking at system level changes like multidisciplinary, much like you would get from a super users group, I don't know, in Epic, things like that. And that's really allowed us to make a lot of changes. Like you need a lot of heads in the room if you're don't have an EHR, right? And Dr. Curl and is making briefing books. I mean, she's helping us spearhead a lot of these things through the clinical service board. She gave us access to a lot of facility medical directors that know what they need to see, right?
I would just say that yes, I am obsessed with having briefing books, and yes, I am obsessed with sharing data with people. But the one thing that I always come back to is that this is about patients, and that's something that's worth putting in on a sticky. Whoever your central client is, your real central client, remind yourself that it's not about, you know, whether or not you're clever enough to manipulate the system or get at the right data or all that stuff. It's actually is what I'm doing lifting the circumstance of my central client? Is am I having the outcome that I want? Because, you know, Rain and Kate and I work very hard. All three of us are very driven women, and we all, you know, want to believe that what we do every day is something, you know, that's worth doing. And that pausing to evaluate whether or not you got it right or you can get it even more right is the big thing. That really is the big thing is um if we can get down to 22% recidivism rate, can we get down below 10? And if so, in what way can we do that? And how do we help fewer people have to come back and learn the lessons of going through a system that can be re-traumatizing for people? You know, and if we can continue to do that year after year, we're going to get at a system that actually works, and then we can share that with America and share that with the world of how do we have um, prisons, which you don't think of as a healing space. I know none of us probably before we were involved really got that, but how do we have that be a restorative space where people actually get the benefits and the support that they need to learn the lessons that they need to learn to fundamentally change their path going forward? You know, Rain talked about the path coming into prison and the path through prison, and I think we spend a fair amount of our time curiously thinking, and what does the path after this look like for this human? And how can we make it where they're equipped for that path?
Mhm. Wonderful, thank you. Another good question, how do you balance your emphasis on peer-to-peer ownership with a DOC culture that is careful, protective, and very hierarchical? Did I say that right? Historically, I'm just gonna move past that. You know what I'm saying.
Not very well. Would that answer that question? I don't know, Rain or Kate, do you want to take, 'cause I have no patience for the hierarchy, and so I have to always remind myself that there is that thing, and that there's, you know, all the political stuff we all in state government. I'm not saying anything controversial here, but have been through as we're, you know, getting a new governor after having Governor Inslee for, you know, 12 years and going through all that. We call it kind of on the inside, you know, a little bit of a silly season where just everything feels like it's a little more chaotic than is really beneficial. Um, uh, what has to happen sometimes when you're in a place where people feel vulnerable is the internal dialogue, kind of conversations have to be a little bit quieter and a little bit less in a crowded room and more behind the scenes where people can, kind of process, when they're not on display. If that makes any sense. It's like having tender conversations with people around meaningful things in a place where they can maintain their ego integrity and not feel like they're on the spot. Because we're all healthcare people. We all are curious by nature and really just want to kind of get at, what's the best thing to do here. We don't come from a background where we're told to, you know, uh, command and control and obey and do, things by procedural, manuals and things like that. And so that sensitivity around that the culture that we're intersecting with, um, has reasons why it's grown up that way. It's not because of bad people. It's actually quite the opposite. It's because of really good people who want to have safe spaces for, our residents to live in and for people to work in. And so then it's that tenderness of that conversation of having the situational awareness of when can I kind of explode this conversation and when do I need to quietly go behind the scenes and carefully have a tender conversation with someone.
Wow. Thank you for your service and your tender heart in that arena. There was a question that was posed in chat and Rain did answer it, but for the folks who go back and watch this recording later, you may not be able to see the chat. So I'm going to go ahead and address this out loud. And Rain, if you want to speak to what you said in chat, you can. So the question said, your data showed percentages of people who dropped out of, I don't remember off the top the acronym, but out of WET, SHARE, and CPT services. Do you collect data on why people dropped out? And if so, what trends are you seeing?
So you want, yeah, just for me to say words, I can say words. So yes, we did collect the data. One of the cool things about the metrics is it collects data on everybody that goes through treatment and actually is helping us really understand that better. So we can actually filter our data by treatment completion status, like who's dropping out, who's still engaged. So, I mean, clinically what we're seeing is sort of stage of change. People might be engaged at a high level of treatment when they're not quite ready. So we need to do more motivational interviewing, which has actually helped us to kind of work more from a stages of change model, which has been really healing and powerful. And also sometimes people with certain symptom patterns. And so that has helped us sort of get better at just like matching clients and treatment to go back to that, like reducing burnout. Because we can have a client and a therapist in the same room at the right stage of change at the right time. Not only does that client not drop out, but that's a super highly productive experience. And also both people feel healed through that. And so, yes, we absolutely do that. It was a great question.
Oh, I love that. So intentional in your process. That's it for questions. We do have time left over, and so I want to pose this to the audience. And, it's okay if you don't have anything, because I know some folks are processors and it might take you time and I don't want to put you on the spot. But if there's anyone here who's been listening to all this awesome work and this great presentation, if you have any, I don't know, golden nuggets that you're going to take away with you and walk away with, something that really stuck with you, we'd love to hear you come off mic and share with us. If you'd like to share, we've got the time for it. Hi, Mercedes.
Can you hear me?
I can hear you, yes.
Wonderful. Hi, good morning. My hair is put back. This meeting just kind of gave me the re-inspiration I need. I'm so sorry for those. My name is Mercedes Becky. My pronouns are she, her, aya. For those who cannot are visually impaired, I'm wearing glasses. I have brown hair tied in a messy bun, and I have SpongeBob sweater on. So that's tan. I'm from the Division of Vocational Rehabilitation, and I am the administrative assistant to the regional administrator in Area 1, which is Eastern Washington, Angela Merritt. And all of our counselors are like, we're all motivational interviewing. We make sure that that's a toolkit that they have. But with what you're speaking to and having that resource network, we are focusing on engagement sooner. We're ending the foster to prison pipeline because we work with working with the school districts. But I would love, what I'm taking forward is your platform, because we hear what our staff needs to assist our customers, those within the disabled community. And then they're doing such a great job of trying to empower, but just to see the success and the rates of what your data shows, I can't wait to take that too. I actually have my check-in this afternoon, and I cannot wait to show it so she can present it to leadership and let them know that they're seeing a successful partnership. You're seeing a successful planning, and that's what we're trying to build too. So how are we getting them sooner? We're recognizing those traumas in the kids, not after they graduate and they get to us at 18. Let's get them sooner. Let's get them the resources, and that's can extend their education, because sometimes you just need those social interactions, especially in those targeted demographics. And so I come from Kaiser Permanente originally. I'm only 3 years public service, but I've always been, I'm a health equity access team member for Kaiser National. So y'all are speaking my love language. And I feel like Dr. Curl, me and you are right there in our journey in this path, because I was so fuerte and passionate. Like, we need to make these changes. And now I'm learning my first crazy or silly season, as you called it. You know what, guys, it's gonna be okay. I'm just here. Like, we are gonna be okay. You're gonna be okay. And I'm just cooking for everybody. But thank you so much. I really appreciate everything that you all shared today. And that's what I'm taking back to my agency.
Oh, I love it. Wonderful. Thank you for kicking us off with that awesome testimony, I'm going to say, of what you got from this presentation and what you're taking back. Thank you. Anyone else feel moved to share? We've got time.
There were a few good inputs in the chat, Talia.
Yeah, I do see another question. Let's go ahead and address that. What possibilities do you see for preventing infraction through preventative care and trauma intervention?
For preventing infraction through code. Oh, this is great. I mean, I think there's a lot. I'm sure my partners might have things to say too, but as a clinician, I see a more meaningful process for incarcerated women where hopefully they're getting less sanctions, they're getting treatment, trying to say that carefully. But a lot of times these behaviors that stem from untreated substance use can lead to these infractions, which means that women are experiencing sanctions during a time of trauma crisis. And so my hope is, if we are, as the research appears to show, reducing these infractions, that women are having a different experience, right? A healing experience like Dr. Curl was talking about, that hopefully then translates to the community. I would love to see that at some point. At least that's one of the things I'm thinking of, and anyone else is free to comment.
I would just say that when the only tool that you have in your hand is a hammer, that's the tool that people will use. So for people like Dr. Carei and Kate and myself and the leaders that we work with, what we have to do is give people a different toolbox, a more complete toolbox, and we have to prove to them that the compassion tools actually work better than the sanctions and infractions and those things. There's a time for hurry up and get things safe. And then there's a time to, be a little bit more pondering as to what does this human need. And we have to just keep speaking that into the environment and continue to prove to people this is not something that's unique to prisons, though. You all know in your supervisory responsibilities and your interactions with the people who supervise you, that the people who kind of truncate and get frustrated and go directly to the negative kind of behaviors and the negative sanctions are probably the ones who just are unimaginative and least talented. Maybe they're super frustrated in what they're doing. And so it's a system-wide kind of a thing that we can work together to say, healing people, healed people heal people, and healing people can help that happen. And we can do that. There's a really great book, actually. I don't know if I can get it, Compassionomics. It's kind of it's a book that I am obsessed with. I've given it to a lot of people, and it's about actually it's a compilation of thousands of research hours and meta-analyses on why compassion actually is the responsible economic path. It's the one that makes the most business sense, and not just for healthcare. It's for running state government. Actually it saves us so much time, so much grief, and so much turnover, so much money. And eventually we'll be able to see it gets us the outcome faster too. So I would buy this book. I'm glad to get anyone a copy as a loaner. I've got a bunch of them.
Took a note of that one. Thank you. Two things.
The other thing with infractions, though, like from a correctional standpoint, is it's something that we all connect to. Like we don't have all the movements and all the things that we need because of security constraints, because correctional healthcare is different than every other healthcare. So when we're looking at a metrics, it's also like good to have something that's like connective to all different modalities. And at the CEQIP meeting, every one of those members is there too. And so when you're looking at data that's not just medical based, but has more inclinations to them, which at every CEQIP meeting, we're reviewing resolutions data. We have about 6 different dashboards, and we're looking at it a lot of different ways and a lot of different like whys. And we're seeing cool trends. Like most of the time we're getting resolutions or like, and I mean, just different things like infractions, resolutions, different modalities coming together to look at something that relates to clinical, but also relates to that custodial, right?
Thank you, Kate. Yeah, and I just wanted to say a couple things you said, Dr. Curl. Healed people heal people. I love that. I've always heard broken people break people, but I never heard the positive flip side of that. So how powerful is that? And also, I just want to say, am I the only one that wants a list of Dr. Curl's obsessions? Like, I feel like everything that she said she's been obsessed with is something we can really learn from. And I want to go research and dive deep into it because they seem like really good things to be obsessed with. I also want to share there's some good insights in the chat for folks, if you're not seeing that, or for people who watch the recording later. We were asking, what are some golden nuggets you took away from this presentation? And so Amy took a snippet of the culture and says that it's a vital link for positive growth. Examples of ways to attempt to improve culture are her biggest takeaway, and she appreciates the opportunity to learn from you all today. What other, let's see, nuggets from Jay Hodge. What can we do with what we have and be the change? Move forward anyway is something that they're taking away as we elevate ourselves and lift others. I'm just going to say Hodge because I'm not sure what the J stands for, but you are a project manager supporting reentry initiatives for Medicaid members. Awesome. And this has been very inspirational. Thank you all for your presentation and your caring energy. Megan shared a link. Let's see, today's WTB newsletter and October's may also be interesting to DOC folks and others working in the behavioral health and corrections in Washington State. Thank you for that link. And let's see, we've got Joe Monroe. So pleased to see that you continued this work since the Florence experiment. Love the Compassionomics book and has never met anyone else who is a fan. So thank you. Let's see. Yeah, awesome. So many good comments. Let's see. And I think we have one more quick question. Are you tracking infraction types?
Yes. Okay. So I wish that I would have remembered that. So thank you for being the plan, the audience. I'll pay you later. But yes, we specifically look at infractions that are related to trauma. And I should have said that is actually our research is focused on those infractions specifically. So aggression, substance use, medication misuse, anything that we think could be driven from a trauma perspective are the infractions we're seeing decrease. So thank God for you. Thank you. I forgot to say that. That was critical.
Awesome. Thank you. Okay. Well, let's see. I mean, there's such an engaging conversation. There's so many comments coming in here. All right. Well, we've got 3 more minutes. Is there anyone that would like to come off mute just to say a quick thing to our presenters?
Thanks for being great role models in public service, dare I say.
Awesome. Yes, thank you. Okay, well, with that, you all are wonderful. Thank you so much for sharing with us, not only sharing your story, but sharing your passion, sharing the inspiration, sharing that energy, that vibe for all of us to walk away with and to remember the great takeaways that we had and to be inspired to go and do our work and literally be the change in our work. When there's things that can't change, we can just be that change by finding that passion to do what it is we love and help the people that we're there to help. So thank you so much. I am looking forward to going back and watching this re-recording, as I have gone back and watched the recording of our reflection series, Rain. So again, you all, I will send out a blast. You know how we do it. We send out a blast with a recap of what happened today, as well as links that you can go back and watch or pull up materials. And if you haven't already, fill out the survey. Let us know what you thought about today. Was it applicable? Was it helpful? We already know the presenters were engaging, but fill that link out anyway. I think Teresa just put it in. All right. Thanks, Teresa. She's all over it. Okay. Have a wonderful day, everyone. Thank you for joining.
Thank you. Bye.
Bye. Have a great new year as well.
Happy holidays.
Happy New Year! Woo! Last day of the year.
Woohoo!